Thanks so much for joining us today, Dr. Adolph.
Thanks for having me. How are you?
I'm great. I'm really excited for this discussion because ketamine is one of my favorite things to discuss because it is available. It is
Yeah.
legal. This exists. There are so many things that we discuss on this podcast that people have to travel to a different country to obtain, or that's in a clinical trial still, and it's almost available, but ketamine is here. So
Right.
I would love if we
Yeah.
could start by having you tell us a little bit about the history of ketamine and how we got to this point with it.
Ketamine, interestingly, was actually the second attempt at trying to create a new anesthetic. In specifically militarily, we lost a lot of men in the field when medics were using morphine. So IM morphine was being used kind of universally, and when administered in the field, you're dose dependent, you could be causing respiratory depression because it's an opioid. And so they were looking for something that was more of a complete anesthetic. And the first drug out of the gate was PCP, which we all know some of the effects and the street use of it. But knowing that PCP was such a powerful hallucinogen, it was also had great properties as analgesic. And so they went back to the lab table, then did some bench work and created ketamine. And that was around in the 60s. So in the early 60s, when ketamine came out, it was used in Vietnam. And knowing that it's got this wide therapeutic window, and what I mean by therapeutic window is that it's very safe. And so it doesn't cause respiratory depression. It increases heart rate. It increases blood pressure. And so as an anesthesiologist in the operating room, it's a very great drug to have on hand when we have sick hearts and patients who, say, have lung disease. It's a great anesthetic to be able to use as an adjunct because it's not going to decrease respiratory drive and it's not going to decrease heart rate. And we all like that. We like blood pressure in the operating room. So
That makes sense. And so
yes.
you're saying it was initially used as on the military field, on the
Right. It was
battlefield.
initially used, it was called the buddy drug. And the reason being was that the medics would be able to use an intramuscular injection in the field. And it created analgesia. It's a dissociative. So it created a way for, that soldier or that injured military person would essentially not have any somatic uh, input and did not feel anything. So they were able to, again, be sedated and also have an analgesic. And of course, the most important thing was breathing and not having to have someone attend to their airway and making sure that they were watching that. So it's kind of a hands-free situation for a medic where they can inject it intramuscularly and then have, all the abilities of the operating room in the field, essentially. So, um, but again, it's, I think it now, the World Health Organization created it as an essential medication. So that in further protects it as a drug for us to have, even as an off-label use. It's very important because it's used worldwide, say in third world countries that don't have ventilators, that want to, of course, obviously have care for people in small clinics where they don't have to walk or travel long distances. Physicians, surgeons can do minor procedures just like they do in the ER. Great for little kids, safe for children, for lacerations. Of course, we see it in vet offices used. It'd be awfully hard to try to put a breathing tube in a horse or a cow. So it's used frequently across the board. Great drug. But again, it wasn't just for anesthetic uses. It started to become more widely accepted.
And can you talk a little bit about how that use morphed? Like, how did people first start realizing, like, oh, this has a use above and beyond just what we were using for anesthesia?
Right. I, as most discoveries, it was by accident. And one that really comes to mind was in the beginning stages of the Gulf War, where we had soldiers coming back, either burned mostly, but also having other injuries from war, and in the ICU, particularly in a burn unit at VAMC down in San Antonio, that when they were undergoing debridements, there were a subset of patients that were getting bedside debridements with ketamine. There were others that were receiving propofol, and that was just by the choice of the provider. And, it was propofol and some other analgesic, because propofol does not have analgesic properties. But they found that the ketamine treated patients had less post-traumatic stress. They were able to really relive their traumatic experience and see it in a different light, kind of through a different lens, so to speak. And they would, begin to converse with their providers who were taking care of them. Of course, the ICU nurses who were staying with them, talking with them, they would have a reliving. And it was, again, by accident, found that some of these patients were able to work through some difficult issues, and on the backside of that have less depression associated with their trauma.
Wow.
So around 1999, maybe in 2000. And so it from there were small studies that were done. Probably the most was 40 patients. And if you were to compile all of that research, you would see that the response rate is about 60% in depressed patients. And that's, again, anywhere from 1 infusion to 6 to 10 infusions. And there have been studies done that show with one singular infusion, you see response rates of 60 to 80%. And that antidepressant effect is immediate, and it will last up to 7 days. But kind of that bell shape, the fat part of the bell shaped curve is about 3 to 5 days on a singular infusion at 0.5 milligram per kilogram over 40 minutes. And that's the NIH, after about 15 years, the NIH did probably one of the larger studies that showed that the sweet spot was about 6 infusions done over 3 weeks. So 2 infusions per week, and at 0.5 milligram per kilogram. So they did not adjust dose. They stayed at that dosage, and they saw, again, the same response rates. And, some of the studies that have been done on especially suicidal ideation is extinguishing suicidal ideation within 24 hours. And that we see, a lot in the emergency room, because somebody that comes in that's suicidal, that's a direct admission in most places in the country. And I think some smart ER docs have started to utilize that, the results that they had seen with that one study, that patients will no longer be suicidal. They're watched in the emergency room for a period of time. They get in touch with an outpatient center, and they were able to be free of that. And that's tremendous.
Yeah.
We don't have that in pill form.
No, we definitely don't. That's incredible. Thank you for adding that. I was going to ask that part about suicidality, because that's such an important point in here. Now, with the studies, for example, the NIH one, how
Right.
long were they showing that protocol of 6 within 3 weeks? How long is the antidepressant effect usually last?
Well, again, if you were to look at the average was 4 to 6 weeks. And again, most of these studies that were done were either SSRI naive patients who these were not, most of the studies that I'm quoting are not studies done on treatment-resistant depressed patients. So that let's say the antidepressant naive responds at a much higher rate than those people who are either on multiple antidepressants. And there's yet to see, at least to my knowledge, of any really long-term studies to show treatment-resistant depression on one SSRI or mixed, serotonin and norepinephrine reuptake inhibitors. We haven't seen those studies done, but I know later in the podcast we'll talk about my experience in the clinic and what we see. But you can imagine, I know that you've had this conversation on this podcast, that SSRIs changed your brain architecture, and so because of that, it's going to take a longer period of time, more than 6 infusions, which the NIH shows. And, there's other protocols which I can discuss, what they've done and looked at as far as the dissociation that ketamine causes and what that state means, and, how important it is even after one infusion.
Yeah, absolutely. And I wanted to bring up here, like you alluded to when we discussed on the podcast last week, for anybody who heard it, that ketamine is one of the psychedelic medicines that you can take while you are still taking antidepressants.
Yes.
There's no, which, if somebody's afraid of, okay, I'm afraid of tapering, but I still would like better results than I'm getting, this is one of those options for you. But yeah, I would love to hear a little bit more about what you were mentioning with the dissociation and those effects.
Yeah. Well, before I get to that, I want to answer to, there's also a concern of SSRIs having the that flood of serotonin in the usage of, say, an ayahuasca ceremony where DMT creates that, and you can have that surge and a storm, and if you're not off your SSRIs and go to ceremony like that, it can be dangerous, and we've seen that and heard about it. It seems with ketamine that monoamine oxidase inhibitors are safe. We do not see it, and most of the patients that we see on those drugs, and again, like I said, are slower to respond because of the. I believe it's more the length of time of depression. If you're depressed and have been depressed for over 10 years, the studies, again, animal studies, rat studies, have shown that the hippocampus will atrophy. And one of the main benefits of ketamine is in the downstream sequelae of administration, you see the release of BDNF, which is brain-derived neurotrophic factor. And those that will wake the brain up. And, along with, of course, glutamate, which, being that ketamine is an antagonist at the NMDA receptor, and that's where, glutamate wants to get to it. If ketamine is there, it's the excitatory neurotransmitter, but it also helps that surge of glutamate will help us repair our brains. Essentially, it rewires us. And we can talk about later on about integration and how important integration and the usage of these practices while you have neuroplasticity, while your brain is being rewired, while we're relearning and trying to stop that rumination that we often have, that highway between the prefrontal cortex and the hippocampus that we just want to say, shh.
Yeah. Right. Take a break for a second.
Take a break.
I appreciate that. And yes, I'm definitely excited to talk about integration at the end. And it reminds me of a question that I was going to ask you about those other studies, because I know you're a big supporter of MAPS, and what MAPS is doing is, they're doing the MDMA with the psychotherapy. But if I am understanding right, all the studies that have been done on ketamine have been done in the absence of any psychotherapy. Exactly.
All the studies that I just mentioned were without, it was just the drug and just the antidepressant effect of the drug itself. Like, they felt immediate relief without any, even, again, psychotherapy during the infusion. At a 0.5 milligram per kilogram, that's a dose that you could still have conversation. Maybe not, all patients, but most patients would feel euphoric and be more open. But I would say if you were going to do any integration, that's the most amazing thing, is that the drug is no longer in your body. but the receptors have been turned on, the neurons have been turned on, and it's so important during that series, during that month or 6 weeks, while you're getting ketamine, that you do begin that integration process. But there have been studies to compare ketamine without integration and then ketamine with integration, and it's about a 30% increase in results. And so more people respond, and they respond more effectively.
Oh, that's great to hear. Thank you for sharing that. So we talked about the protocol before, like the one I think most ketamine centers that at least that I've heard of are following something closely to that NIH protocol,
Right.
with people with maybe less severe depression. But you were talking about those that, and I love that you described that if you've had, long-standing depression, you've been maybe on medication for a while, that your brain has had these changes. And so ketamine is not only likely to eventually bring you the antidepressant benefits, but it's also healing your brain to make it
Right.
more receptive to those benefits as the process
Yes.
goes along. So can you talk a little bit about how that protocol is different for those?
The protocol is different for, say, those that have been on meds for a long time.
Yeah, or with really long-standing depression. Is it that they need more, or that there's just less time in between their 6 sessions?
Well, we do try to do the same protocol, but like you said, the way that they may differ is that the infusion number is extended. So typically, there was a recent study that said that NIH study of 2 per week for 3 weeks, they said there wasn't any difference than if the patient received 2 in the first week and then 1 per week in the subsequent 4. So there needs to be more studies done on how often do we really want to provide ketamine, and how long is the effect that we see. But to get to your question, it's individual. So if a patient comes to us and they're on 3 SSRIs and they've been depressed for 20 to 25 years, a lot of times we will see response in an 8th infusion. And part of that is, again, as you know, just in medicine in general, compliance by patients is so important. A lot of times with ketamine and any other drug is that it puts them in a space where they're able to revisit integrating again. A lot of the patients that have come to us have been patients that have fallen away from the mental health field in general. Their medications are being managed by just their regular PCP or their family doctor, and they haven't seen a therapist or a psychiatrist in years. So the drug, we like to say the first few infusions are like shaking hands with ketamine to get to know the drug, and then it begins to open them up to, you know what, I'm ready. I'm ready to start taking a look, because that's what we see is that patients are more open to take a look at trauma. They're more open to see that their mindset is important in being able to produce a more positive response. And so the real answer is it's patient dependent. And we, of course, have a network of people. Most people that come to us don't have a therapist, but we have a network of people that we refer them to, and we want them to begin integrating almost immediately. Now, if they're suicidal, we want to get them into the chair and have an infusion as soon as they can get in. But every patient's different, and our protocols vary according to the patient.
Yeah, that makes sense.
Yeah.
And I was wondering, because I when we had our first series of ketamine discussions on the show, I believe it was that the 6 initial sessions go on, and then after some period of time they need a booster perhaps. And
Right.
does that
Right.
look like 1 or 2, or do they go back through the I mean, I realize of course this is patient dependent, but in general, what does it look like when that booster series hits?
I think so. I don't want to get too far in the weeds here, but I'll try to break it down to what we really see. And, of course, when you're in a series, it's an intensive process and you're all in. And so we are coaching them when they come in. We're reaching out to them to see how they did 24 hours after an infusion. They're beginning to, again, integrate using meditation, journaling, gardening, the things that we suggest. Plus, they want to see their therapist, and we want to, see how they're doing, let's say, on their second infusion, and to see what may have come up. Because typically what we see with ketamine is that as the infusion series progresses, by the third infusion, you're beginning to get some dissociative effects, and it begins to bring up emotions that, of course, have been suppressed either by medicines or by our, of course, coping mechanisms, which vary from patient to patient. But it's a trash compacting of emotions that we see, that it's starting to come up, and we have to really let people know, expect this, because that's where the juicy, mark is, where you really need to delve into feeling that emotion, sitting in it, and knowing that it's not ketamine that's making you worse. It's ketamine that's showing you the things that you need to work on.
Yeah. And so after they finish that 6 series and say they're better for, like you said, maybe the 4 to 6 weeks,
right,
do they come back and have one session, or do they do the 6 over again?
I'll just kind of randomly pick people. Let's just say a high-functioning CEO who's just gotten divorced, who's trying to get on with his life, but just seems stuck, comes in for a series, feels fantastic, and we prescribe microdosing as well, and begins to microdose and is moving along, and we haven't, let's say, seen him for 4 to 6 weeks. We check back in, and he's like, "I'm doing fantastic. There's nothing going on. I'm doing great." Some patients like that, who have never been on a drug before, go through a full series, begin microdosing, and may do fine for 6 months, and then there may be something that comes up that triggers them, and they realize, you know what, I need to go back. And we suggest coming in for a booster. There are other patients we have that are severely depressed, that, again, they're in the middle of their integration at the third infusion. They're starting to see some benefits. And in those patients, the people who we expect, if you've been depressed for 2 decades, let's be patient. And so let's work with meditation, cognitive behavioral therapy. EMDR is wonderful, especially for patients with trauma. And when we see patients like that, one patient in mind with, again, the history of treatment-resistant depression for 20 years, was not seeing the results that she would like, but we suggested EMDR, and she began EMDR, and within 3 days she was back and wanting another infusion to work through some of the things that had come up. So she's doing fantastic, and she was getting a booster once every month, and now she's spread it out to about once every 3 months.
Nice. So it's not that it requires going back through the 6. It may just be just that one additional session.
Yeah. Yeah, it would be rare to suggest somebody go through another full series.
Got it.
Unless, of course, they're seeing a psychiatrist and they've had, some specific event that really sent them back down to a place where they've completely shut off.
Yeah, I understand. You brought up something that I'm sure everybody's ears perked up. What are you having people microdose?
Well, ketamine.
Okay, that was the question. Are we talking that leads perfectly into my next question, so we'll discuss what they're microdosing for you. But my next question was going to be about the other administrations, because right now, we've been talking about intravenous infusions. You're sitting there, you've got the IV in, you get it over about 40 minutes, like you said, but people know that there are nasal sprays, there are lozenges, there is rectal ketamine. So if you could tell us a little bit about how you're having people microdose with ketamine, and then we'll get into a little bit of those other administrations.
Absolutely. So our typical protocol is on the third infusion, as it's, again, like I said, as the emotions begin to come up, and they may struggle for that week before they have another infusion, we'll begin microdosing. So there's intranasal injections. There's lozenges, essentially like a gummy bear or like a Starburst. And there's also rectal suppositories. So those are our three main ways of being able to microdose. In my experience, and again, we've been almost open 2 years, my experience is that nasal spray is the easiest because it's very rapid onset. And if you have, let's just say you're ready to begin your integration in, say, meditation or a float tank, and you use the nasal spray and you get into, a quiet place that you can begin integrating. And that's, again, how we coach people to use microdosing, not like, hey, I feel like a glass of wine. There's responsible use that we discuss with the patient. But I would say that there are disadvantages to using the intranasal route, mainly because if you have sinusitis, or again, in Austin, allergies are pretty bad pretty much year round, that if your sinuses are not able to absorb the medication adequately, it's just a postnasal, drip, and you're only getting about a 30% effective dose. So we begin to look at other avenues, but for most people, it does work. However, with lozenges, you have first pass effect. For those that don't know, that's the liver consuming what you really want to have in your bloodstream. But with the rectal suppository, you have a bypass of that, as well as of course, the intranasal. So I suggest for patients who end up kind of, especially anyone with addiction, because with the intranasal route, you have a tremendous amount of dopamine that's released because it just hits the brain and you get this dopamine happy, response, which you do not see with the lozenge or the rectal suppository. And then the rectal suppository has just, if it's 100 milligrams comparatively, I mean, if you don't have the liver, chewing it up, you're going to have more. So you have a longer period of time instead of with a lozenge that may give you 40 minutes. The rectal suppository could give you double, like an hour and a half.
Wow.
Yeah.
I really appreciate you bringing up the addiction potential and how
Yes.
I hadn't heard that before, and that's a really fantastic for people to take note of. This is one of the few psychedelics that does get into the scarier addiction realm, and so I appreciate you pointing out the differences there.
Yeah, what's interesting is that I can't find I've gone through a full series myself, and I received boosters as well. I think that it's important for me to understand that, but I have a reason. I've suffered from generalized anxiety all of my life, and I find that it has changed my life. Thus, the reason why, struggling with that. That's not why I opened the clinic, but I knew that there was a better way than using an SSRI because I couldn't metabolize. That's how I actually came to it. I had the wonderful genetic mutation in the MTHFR gene, and it gave me nightmares and all of the side effects. So wasn't a fan and struggled a lot. So turning to psychedelics and turning to other means and being able to understand has really opened my eyes and my mind, of course, to know that really the subconscious is the place to tap into, understand our ego, understand where we are trying to protect ourselves, and how we can understand what our triggers are. And of course, gratitude and being able to understand our lives and the people around us a little better.
Yeah. Well, thank you for sharing your personal story with us. I really appreciate that. I had not heard that before. So thank you for sharing. And that's a great lead into, I would love to hear some other anecdotes of those who've used depression successfully with ketamine in your clinic.
Well, I think that, as you know, there's more than just depression, but I'll focus on depression. And I think that with depression, it really can, I think that what I believe now, after opening the clinic and seeing so many patients benefit from the infusions, I think that, of course, the younger the patient, I like to see teenagers to, the early 20s, that sector of the population that are what I call the failure to fly, maybe had helicopter parents, suffer from depression and anxiety, or just depression, because they go off to college and they feel completely lost. They come back home, they don't know why they're depressed. Nothing is really, coming to them, and it isn't until they understand their subconscious, what they're telling themselves over and over again. I can't do it. This is impossible. I need help with this. And their responses are, I would say, in the upper 70 to 80s. And so there's a 19-year-old girl that I know that was early on in us opening the clinic, fit that to a T, that description. And she did wonderfully. And again, it was over the summer. She had 3 months of treatments, boosters included, and she was able to go back to college. And, again, I want to make sure that I mention this, is that ketamine is just a tool. These are all of the medications that we have on hand are tools. And I want to mention that all of our patients are going to vary with the amount of integration, the amount of change that they see. But the longer lasting effects come with a change in perception and a change in lifestyle. And, all of those things come with being able to have just a little bit of ego dissolution and be able to understand that sleep is important, eating's important, moving our bodies is important, and having a balanced lifestyle to be able to have ketamine work better than just hitting the receptors and creating a change in our neurotransmission.
Yeah, absolutely. Thank you for pointing out that
Yeah.
crucial information at the end.
Yeah.
That leads us into, what do you recommend for integration for your patients?
I'm going to be patient one and call myself out on it, because I have a busy life, and that's the first thing that you'll hear out of anyone's mouth is, I'm so busy, I can't. But it's 5 minutes of meditation, it's 5 minutes of breathing, and that's where it starts. I've always known, as someone who's suffered from anxiety and depression because of my anxiety, that exercise was absolutely, my number one way of being able to relieve myself of some of these, because of the endorphins and the other wonderful dopamine releases that you see with exercise. But if you can't exercise, then you have to have other means. And, for me, it continues to be exercise is number one, but also it's, again, having a daily practice of gratitude. I'm a big follower of Stoic philosophy. I read that every morning, and it puts me in a positive frame of mind to face the day. And that the Daily Stoic is the website that I would highly recommend people check out. It sends you an email every day, and it gives you a modern quote from someone, and then a quote from one of the early philosophers. And I just find it to be a great way to get you into a positive frame of mind. But there's float tanks. I mean, we partner with Ocean Lab. It's right around the block from us. They're fantastic over there. And, that's another way, with microdosing and without. I mean, it's amazing how well you sleep after you turn your brain off for an hour or an hour and a half, or however you want to go and do that. But when we start with patients, we suggest integration techniques that fit that person at that time. Obviously, if someone comes in that's suicidal, we're trying to extinguish suicidal ideation first, and it's baby steps from there. And so integration can look like interacting more with your family members when you've microdosed, because it gives you a place to be able to go and sit with your family members where maybe your depression had prevented you from interacting. So it's bolstering family relationships. Those are things that are going to increase, of course, all of those wonderful feelings that we get, oxytocin and dopamine. So it looks different for everyone. And again, this isn't solely done in our clinic. We're coaches along the way. We're not mental health providers in the clinic. We're providing a means and a guide. So our network of people and ways to integrate is anywhere from life coaching and therapists to psychotherapy and EMDR. So journaling is great. We have a patient that loves to paint. We have another that is a gardener. So these are all things where you're completely able to be in your space and get away from the phones, the technology, and be able to feel the emotions and think through them.
Yeah, I appreciate that. I love that you brought up EMDR and cognitive behavioral therapy, because I think, we hear so many of the same kind of integration things, which are essentially like just go be with yourself in a,
Right.
like you said, put the phone away, find some peace, find your moments of joy. But in
Right.
addition, there are those other modalities that, if you've only done kind of just like basic psychotherapy before, and then you add this, well, that's a good reminder that this primes your body for that EMDR, which is very good for trauma, or cognitive behavioral therapy, CBT. Same thing, like those are kind of additional levels of integration that the psychology world offers to us, that
Right.
I'm glad that you brought those to the
Yeah.
forefront.
Yeah, and I think that it's important also to recognize that, being that it's the drug that we have right now, and we understand that it's like we're riding this wave of things that are coming on with, the wonderful work that MAPS is doing and other, places around the country, in the world. It's that we look at ketamine as, again, a tool. And when we can get into the science and figure out how this happens and how does it get us into this frame of mind and what is dissociation, people have often asked me to describe dissociation. I'm sure you've probably had that conversation on this podcast several times. It's like, how do I grasp that snowflake and, put it into words? It's different for everybody, but you can imagine how much our body sensation is affecting, it's getting in the way of how we actually are able to interpret our emotions. And sometimes we're interpreting our emotions from our somatic injuries or pain. And so, I think that it's important to understand that we believe that period of dissociation where you're no longer really fully conscious, that you're in a dreamlike state. I find that as fascinating compared to the other psychedelics that you've probably discussed of psilocybin and LSD and some of the drugs that are more serotonergic, where you are conscious and you're feeling these emotions and you're working on those things as almost a place in your head that you're given the space. Ketamine's more of a dreamlike state where things don't really make a whole lot of sense. But then on the back end, like you said, it's like softening up your brain to be able to take in all of these things, to be able to be more accepting of it. So,
Yeah. Well, thank you for that. And thank you for all the information that you've
well,
provided. How can people, if they would like to find out more about you?
well, we're of course on social media, Instagram and Facebook, but probably the best way is just it's ILLUMMA, so 2 L's and 2 M's.com. And, we have lots of information, lots of research articles, lots of, articles that have been written by patients for Medium. There's a long one that we share that is fantastic. It kind of chronicles this patient's, John Gorman. He chronicles his experience through his series. And it's about a 35-40 minute read. Great. I'd highly recommend it.
Wow. Very cool. I know that people love hearing firsthand accounts. So thank you
Yeah.
for sharing that that's there. And
Yeah.
thank you again so much for everything you shared on the show.
You're welcome. Thank you so much for having me.
Absolutely. All right. For everybody else out there, until next time.